So Penny is a GP obstetrician in Western Australia, formerly part of the EMRAP GP edition called, what was it? Remind me, what was it called?
Right on Prime.
Right on Prime. And she obviously knows much more than anyone else in this room about obstetric things, and she's going to give us an idiot's guide just for me about all things baby related. Thank you, Penny.
Thanks, Nat. Thanks for having me. I always feel like a bit of an imposter at these gatherings of such accomplished retrievalists and emergency people, but you all are terrified of pregnant patients, so hopefully I can help relieve some of that anxiety. So I'm Penny Wilson. I am a GP obstetrician coming from Perth today. I will attempt to share my slide here, but what I'm also going to hope to do is have some video or have me visible as well, so I can do some demonstration with some props I have. So I'm not sure how that's going to go. Can you see my slides? You can. Okay.
Yeah, we can see your slides, and we got you at the top of our screen in the room as well, very small.
Okay, so if you need to make me bigger, then just let me know and I'll toggle the screen sharing on and off. So we'll see how we go. Okay, so we're going to be running through a few obstetric emergencies today. So before I start, I just want to acknowledge that any references to women or mothers is also inclusive of patients of all gender identities who are pregnant. And I'm going to be talking about two or three, depending on how we go for time, different obstetric scenarios to do with complicated deliveries and labour scenarios. And the big secret that we don't want you all to know is that obstetrics is actually pretty straightforward. It's basically a pump and some piping, and a thing has to fit through another thing. So generally, it's pretty straightforward. A person goes into labour, a head comes out, a body comes out, a placenta comes out, and it's job done. Oftentimes with very little intervention from us. But when things get complicated, often it's just a size and shape mismatch. So if we understand that, then sometimes we can work out why something is happening and also how to fix it. So not always do we find a head coming out of the vagina. Sometimes we see this, which is an umbilical cord. This one in the picture has a knot in it, so hopefully we don't see a knot and a cord coming out first, but having a cord dangling in and of itself is scary enough. So this is a cord prolapse. So when we have a cord come out before the baby, that's the scenario that we're dealing with. Now this is not that common, but not that uncommon. It occurs in about 1 in 1,000 up to 5 in 1,000 cases. I've seen 2 or 3 in my career, so it certainly does happen. The reason it's really important to know how to manage it, though, is because it has a potentially a very high mortality rate, up to 9%. So it is important to know how to deal with it in the rare event that you do see it. So basically the mechanism for a, there we go. So mechanism for a cord prolapse. So it's you've got a baby's head that is fitting nicely onto a cervix. So I've got a round thing there and a head there. So it's not watertight, but nothing can really go down in between it. But if you have a high head because you've got a baby that's flopping around in a huge amount of fluid, so polyhydramnios, or you have a foot or a bum or something else, a shoulder presenting, or you have twins, or you have another reason, then you've got a gap there that this little cord can slip down in front of the baby's head, and then you have a cord prolapse. So some of those reasons that we mentioned there, so high head, small baby, twins, breech, unstable lie, polyhydramnios, and unfortunately a lot of these are caused by obstetric maneuvers. So anytime that we do something like we try and turn a baby or we rupture membranes, we increase the risk of this happening. So how are you going to diagnose it? So you may see it. So if you see a cord dangling outside of the vagina, you know that's what's going on. You may also feel it. So if you are doing a vaginal examination and you feel something in the vagina that doesn't feel like a head, you may initially be confused because you might be like, what am I feeling? This is just soft and warm and mushy. But generally when you feel a cord in the vagina, it is pulsing. So that's not a normal thing to feel, is a pulsing thing in the vagina. And you may also hear it. And when I say that, what I'm talking about is the fetal heart. So a sound that strikes terror into all of us is a normal fetal heart ticking along at about 150 that then drops down to 60 or 50 and stays down for a period of time. So that's a fetal bradycardia. That is scary. And when we hear that and we don't have a reason for it, often the first thing we'll do is do a vaginal examination to see or to feel if there is any cord there. And then we know what we're dealing with. So we have two priorities when it comes to cord prolapse. The first is delivering the baby as quickly as possible. And the second is maintaining as much blood flow through the cord as we can. Because what can happen is if the cord is compressed between the presenting part, so the fetal head or the fetal breech and the cervix, you don't get any blood flow through that cord, and then you can get ischemia. So for us in hospital, it's pretty easy. What we're going to do is something like this. So this is a scene from the BBC show This Is Going to Hurt, and a sort of classic obstetric scene where somebody has a cord prolapse. Doctor and midwife then sticks their entire hand into the patient's vagina to lift the head or the breech off the cervix to sort of push it up. And then that hand and that clinical staff member stays there as the patient is being wheeled through the hospital to the operating theatre for a cesarean section. So that is the classic standard management of a cord prolapse. Now, that's going to be a bit different for you guys because you're in a very different clinical context. So you're not going to, I'm assuming, have access to a rapid operating theatre for a cesarean section. So you're going to have to be a little bit more crafty about how you achieve the same thing. So remembering here that the priority is getting the blood flow through the cord as much as possible. There is a little bit of a change in advice around handling of the cord if it's dangling outside of the vagina. There has been some advice in the past about putting warm fluids on the cord. That has, I think, kind of fallen out of fashion a little bit because if those fluids then cool and then you have a cold cord, then that can cause spasm, which is bad news. But you don't want to handle the cord too much either because that can also cause spasm. So what I would suggest is if you have a dangling cord and you've got a bit of a transfer or you've got some time to delivery, tuck it up back inside the vagina just to keep it warm, but don't like play around with it too much. Don't go, ooh, look, this is interesting. Tuck it up and leave it there. Now, it's not going to be very practical for you guys to do manual elevation of the presenting part during transfer. So there's a couple of other ways that you can achieve the same thing. One of them is by, we talked about manual elevation, but one of them is by positioning of the patient, so using gravity to your advantage. So that might be a hips higher than shoulders kind of modified kneeling downward dog kind of scenario, but not quite as relaxing as if you're doing that in a yoga studio. So essentially, if your hips are higher than your shoulders, then gravity is going to help offload that pressure on the cervix and relieve that cord. The other way that's a little bit more transfer friendly is the exaggerated side lying or Sims position. So getting the patient on their side, but with their hips propped up on a couple of pillows, that can achieve a similar thing. Now, the other strategy that's going to be really helpful for transfer over a long distance is filling the bladder. So if you put a Foley catheter in the bladder and then instill 500 mils of saline into the bladder, that is going to have a similar effect to the manual elevation by lifting the presenting part off the cervix and off the cord. So that is a really important trick to know. And essentially, then you're just going to get to your hospital as quickly as possible and get this baby delivered. Any questions about cord prolapse before I move on?
I've got a question.
Yeah.
I don't think I've read this anywhere, but if you're now needing to transfer someone some distance, do tocolytics come into play?
Yeah, so if you're fighting against a really strong contracting pattern, then tocolysis can be useful. in the kind of guidelines and literature, it's more recommended in like an acute setting where you have fetal heart rate abnormalities and you're just rushing to theatre and you use something acute like GTN to kind of quickly relax the uterus just to give you that bit more time. I haven't seen any sort of guidelines about using it over kind of a more prolonged period of time, but I think in theory, if you were having fetal heart rate abnormalities, if you couldn't adequately kind of physically offload the pressure on the cord, that might be something to consider. Okay, so I'm going to move on to breech presentation. So this is pretty common. So we see breaches at term in about 3 to 4% of pregnancies. And actually, you know, I hesitate putting this into an obstetric emergency talk because it's often not an emergency, which is hard for us as obstetric staff to really appreciate as well, because no one really does vaginal breech deliveries much these days. It's kind of fallen out of practice. Most people do end up having cesarean sections, but it is possible to have a totally normal vaginal breech delivery. And so how are we going to diagnose a breech? So again, we might see it. So if you see a person in advanced labour and they have an obvious buttocks at the parting of the labia, then you know that you're dealing with a breech. If you see a scrotum at the breech, at the parting of the labia, you know what you're looking at. Or if you see meconium, fetal feces, then that's obviously something that you don't expect to see if you've got a head presenting. You may also feel it. So you might feel it doing a vaginal examination. You might actually feel the anus or the sort of buttocks, which can be confusing. That oftentimes people get confused by what they're feeling. And you might also feel it abdominally. So the way to feel a fetal head for people who aren't that experienced with pregnant abdominal palpation is that it is a blottable organ structure. So you can bounce the fetal head between your hands and it is firm and regular. So you might feel that suprapubically, you might feel it elsewhere in the abdomen. And of course, the other way that you can diagnose it if it's unclear that we often use is ultrasound. So a fetal head is really an obvious structure to see on ultrasound. So if you are trying to determine the position of a fetus, what I would recommend is that you put your curvilinear ultrasound probe in the sagittal plane suprapubic and angle it down underneath the pubic bone to sort of get that lower abdominal area. And hopefully what you're going to see is a round, bright white structure because the skull is bony. It comes up bright white. If you see something a bit more fuzzy, you might have a breech there. You might also just have a very low head that you can't see. But sometimes if you're uncertain if there is a head presenting suprapubically, you can then move your probe to the fundus and see if you can see a head there, and then you know that that's where it is. So when we are dealing with a unexpected breech labour, breech delivery, there's a few things for us to consider. Firstly is the mode of delivery. Secondly is the place of delivery, and thirdly is the need for transfer. So the mode of delivery is going to depend a little bit on how advanced in labour they are. If they are a multiparous patient, and particularly if they have a small baby, they might just be cracking on in labour and they're just going to have a vaginal delivery of a breech baby without any way of stopping them. And in that case, put your gloves on and be prepared to catch it. If you have a patient in early labour, you may have an opportunity for tocolysis and transfer, and then you're going to decide sort of where is going to be the best place to transfer this patient, or if you deliver in place. So the ones that are going to be the most straightforward are going to be those multi-patients, straightforward breech with small or medium-sized babies. Now, if you have a foot presenting, so if you have a footling breech, this is an emergency. Yeah, that's not a good time for anyone. So you're generally not going to attempt to deliver that vaginally unless you have a tiny preterm baby that is just going to fall out. So sometimes second twins can be delivered by the feet, but generally it's not recommended. So for these ones, you are going to tocalize and transfer generally, and deliver as quickly as possible via cesarean section. And you kind of want to use your cord prolapse strategies for this as well, because it is a very high risk of cord prolapse when you have a footling. So you might have to use some of those tricks about manual elevation and positioning and that kind of thing. But if you have a frank breech, which is bum presenting and feet by the head, or you have a complete breech, which is little ankles crossed and tucked up by the bum, but bum presenting first, then it is an option to deliver vaginally. So let's talk through how a normal breech delivers. So what happens in a standard breech birth is that the fetus is going to come down with the butts presenting in the sort of AP orientation. They're going to curve their little hips around the sacral curve. Then they're going to twist around 90 degrees so that the back is facing the maternal front. And the legs are going to come through, then the arms are going to come through, and then the head is going to curve around that sacral area, and the baby's going to be born. Now, most breeches are uncomplicated, but they can go wrong. And they go wrong when they get stuck. And the couple of places that they can get stuck is across the upper back, and that is particularly likely if they have nuchal arms. So nuchal arms is if the fetal hands are over the head or behind the head or up, rather than tucked in front of the chest. Can you guys see me when I'm doing that? Is that adequately?
Yeah, we can see.
Cool. So yeah, what we want is arms tucked up nicely like this. What we don't want is arms up like this, because that makes the diameter that has to come through wider. And the other place that the breech can get stuck is the aftercoming head can get trapped. And if you have a body dangling and a trapped head, that is scary. So I'm going to give you some tips on what you can do to help prevent a breech getting stuck. Okay, first thing is do nothing. Stand there, hands off, walk away, hands in pocket. Don't touch the breech. Do not pull the breech, leave it alone. Anytime that you pull on the breech, what's going to happen is that you're going to pull the arms up, and then you're in trouble. Next, what you're going to do is you're going to wait until the legs and torso are born. Sometimes you can just when the body is coming through, sometimes you just put a little finger under the knee to help the leg be released. That's okay to do that, but don't do anything else until you see the scapula. Once you see the scapula, then you can put your hands on the baby. Until then, leave it alone. Now, some tips about handling a breech. So, hands on hips. So when you are holding a breech baby, do not hold it around the abdomen. Although this seems like a really obvious thing to do, if you are stressed and you are squeezing a fetal or newborn abdomen, you are putting that baby at risk of rupturing their spleen or liver, which is a bit of a bad look. So handling on the bony pelvis, so hips and pelvis is where you're going to hold the baby. The next thing you're going to do is twist the shoulders. So I might actually stop sharing for this one so I can show you a little bit better. So you're going to be holding the baby by the pelvis here, and the arms are going to be tucked up, and then you're just going to rotate 90 degrees, and you're just going to sweep that little anterior arm down and out. And so that's just going to allow that little space there. And then you're going to rotate 180 degrees so that it's the other direction, and then you're going to sweep out that little arm. Okay, and then we're going to go back to this direction. The next thing that we're going to do is wait. We're going to give it a little bit more time. We're not going to pull at this stage, because if we pull too early, once the body is born, we can end up hyperextending the head, and then it won't be able to come around the sacral curve. So once we see the nape of the neck, here, we can then help deliver the head. So the usual way that we do that is we rest the baby on our hand and arm. We can put our fingers on the baby's cheekbones. So this is in the back of the vagina, and maybe a finger on the chin. And that helps us, it's hard on this one, but it helps us flex the baby's head. Because what we need is flexion to be able to get around that curve. And you can also use your other hand to flex from the nape of the neck. So we need to go this way so that we can get around that curve, and then the baby gets delivered up that way. So handle the baby on the pelvis, not the abdomen. Wait until the scapula are visible, then rotate the torso to deliver the arms. Wait until the nape of the neck is visible, and then help flex the head to deliver it. And you might have an assistant who helps flex the head from suprapubic pressure from the outside. Okay, so that's going to be our main strategy for breech. Any questions about breech? If I have one thing that you walk away here for breech, it is don't pull. Do not pull. That is the best advice. Okay, so we have a few minutes left, so let's run through the third topic here, which is shoulder dystocia. So this is another thing, getting stuck on a thing in the birth canal, that we can help to solve with geometry. So shoulder dystocia is when the head is born and then the shoulder, the anterior shoulder, gets caught up on the symphysis, the pubic symphysis. So it's bone on bone. This is a bony obstruction. It's pretty common, about 1 in 50. Fortunately, not particularly high mortality rate associated with it, but it is common to get injuries from this, particularly brachial plexus injuries from desperate providers pulling on the head in the hopes that it will come, and it will not. So let's talk about the most effective ways that we can deliver a shoulder dystocia. So how are we going to diagnose it first off? So there's two main signs that you look for a shoulder dystocia. One is turtlenecking, is what we call it. So basically, head comes out. Normally the head comes out and then it turns. You see the chin and everything. But in a shoulder dystocia, the head comes out, but you don't really get the full head. You just get like the top part of the head, and then it kind of goes back down. Like, so you get like this high, perineum that just is covering all of the neck and the lower part of the chin. And the other sign is failure of restitution. So instead of the head turning, once the head is delivered, the head stays in usually the OP position, so looking down towards the maternal back. So if you see that, get ready for a shoulder dystocia. So just to remind you of the anatomy, the maternal pelvis is kind of like oval shaped. So the shortest diameter is actually this AP diameter. This bit is the short bit. This bit here, the sort of oblique diameter, is longer. So if we can either widen this space here, so increase this AP diameter, or we can shift the fetal shoulders into a slight oblique plane, or we can reduce the diameter of what's trying to pass through the pelvis, problem solved. So we've got 3 different strategies we can use. Increase the space, decrease the size of the presenting part, and rotate. So I'm going to tell you 3 maneuvers, 1 for each. When we do this in obstetrics, we have a whole huge algorithm which has like 12 maneuvers. It's too complicated. I'm going to tell you 3. So first one is McRoberts. This is the most important one. This resolves a shoulder dystocia in 90% of cases. So this is the knees to nipple position. So you're going to get 2 people, 1 on each side, to pull the patient's knees all the way back as far as they go. And this works by just opening up that AP diameter of the pelvis to give a little bit more room for that baby to come through. And oftentimes that is enough. Somebody's doing traction on the fetal head, and then you feel the shoulder come and everyone breathes a sigh of relief. The second maneuver that's also in this picture is a rotation maneuver. So this person here is doing suprapubic pressure from behind the fetal shoulder. So what they're doing is they're just from the outside, so from the suprapubic area, they're just pushing on that shoulder to try and rotate it just around that pubic area to get into that oblique plane. This is the second maneuver. It's a rotation maneuver. And then the third maneuver, which is the go-to for most obstetric staff because it is the next most effective, is what we call removing the posterior arm. So basically, instead of having shoulders straight across that we're trying to get through, if we can get one arm out, then we have a smaller, now we have a smaller diameter and we can then wriggle the baby out that way. So how we do that is we reach into the posterior part of the vagina and we feel along the front of the baby's chest and we basically just sweep this little arm over the head and then deliver that way. So it's the posterior arm. And oftentimes you can just like flex the elbow to try and bring that hand up and then bring the hand over the baby's face. That is the get out of jail free maneuver for resolving a shoulder dystocia. So first, Mick Roberts, lifting the knees up. Second, suprapubic pressure to get rotation. And third, removing the posterior arm to reduce the size of the baby that you're trying to deliver. Any questions about shoulder dystocia or any other obstetric topics in the last 30 seconds that we have?
No, all good in the room. Anyone online got any questions for Penny? Or we let her escape? There were lots of nods at the beginning when you said that we were all terrified of obstetric patients. Can I just do a quick canvas? Is anyone feeling slightly less terrified? Yes, there's one no, but several nodding heads now. So thank you so much, Penny. That was amazing. A really nice.
Excellent. Nailed the timing. Love that. 8:59 on my clock. So have an amazing rest of your workshop and I'll catch you later.
Awesome. Thank you so much for joining us.